Good evening, everyone. I'm Maureen Wennick. I am the Community Program Manager at the PHACE Syndrome community, and it is PHACE Awareness Week, and we are excited to be here tonight with Dr. Frieden, Dr. Drolet, and Dr. Braun. Dr. Drolet is coming from Wisconsin, correct? Dr. Drolet is our MAB chair and has obviously been with our organization for a very, very long time. Dr. Frieden is from UCSF, and if you were to look up the discovery of PHACE, you would see that Dr. Frieden in 1996 was one of the individuals, along with her colleagues, that has discovered the actual acronym of PHACE. And Dr. Braun is from UCSF, correct? Is that right, Mitchell? And we've known him for a really long time, even before he became a doctor. So we're always excited to have him on board. So without further ado, let's get started. Mitchell, do you have this? Who's sharing slides tonight?
Well, let's see.
One deck?
We have one deck. Beth, I think Beth, you were going to share. You're muted.
I have them pulled up.
Oh, okay. Why don't you do it?
I can share. Yeah.
That's perfect.
Perfect.
All right. Well, good evening. I guess we should go to the. We don't have a ton of slides because we really want to make this a little bit informal and hear from you what you're interested in. So happy PHACE Awareness Week. I'm Ilona Frieden. I'm a pediatric dermatologist at UC San Francisco. And I was thinking actually that next year will really be the 30th anniversary, amazingly, of the sort of acronym being coined, of the PHACE acronym. There were cases before that, many cases, but they were called by a variety of different things. Some of them called atypical Sturge-Weber syndrome, which really is not PHACE at all, and other names. But that was really when I and two of my colleagues came up with the acronym. So next slide. And the acronym PHACE, as many of you know, refers to the P posterior fossa. The posterior fossa is the back part of the brain. I don't know if I can, oh yeah, thank you, Michelle. And hemangioma, H for hemangioma, which is at the moment a prerequisite of having PHACE. We don't really have a diagnostic test to be able to diagnose this without a hemangioma, though we actually think it probably exists. A is for actually arterial anomalies, but also for another complication, coarctation of the aorta, which is the largest blood vessel in our body. C is for cardiac or heart problems. I is for eye problems. E is for eye problems. And S, when people call this PHACES, is for sternal, meaning the middle of the chest. The sternum is right in the center of your chest. So that's the acronym. So I think one of the most important things to understand, and hopefully most of you do, is that not every PHACE patient has everything. And so what I wanted to emphasize here is that the features, the most common would be a large facial hemangioma. That could also be on the scalp and the neck. And that's almost always present, virtually always. We do see patients who have something very similar that really probably is, we call probable PHACE, where it's just on the chest and down the arm or extensively on the chest. The next most common finding are the artery abnormalities. These are the blood vessels that pump blood from the heart out to the tissues. And most common of those are arterial abnormalities in the brain. But other blood vessels in the head and neck can be affected. There's a blood vessel that goes from sort of through underneath your clavicle called the subclavian artery that is often affected. And I'll come back to diagnosis, how we diagnose PHACE in a minute. But when we think about diagnosis, we believe that all patients with PHACE or suspected PHACE should have basically an eye examination, a heart examination, which includes an echocardiogram, which looks in detail at how the heart works, and also the aorta, which I mentioned. Because these are often, they can be present. They're a little bit less common, the eye abnormalities and the heart abnormalities, but they can be there. And when we are trying to figure out other blood vessels in the head and neck, the MRI and MRA are really the best way to find those. So the full face evaluation includes physical examination and sort of history to make sure what's going on with a child, an MRI and an MRA, and ideally that's done with contrast, which allows us to look better both at the hemangiomas and also at the blood vessels, an eye examination, an echocardiogram, and then other tests may be needed depending on a specific situation. If your child isn't growing well, we might need tests to see if there's any problems with hormones that might affect the situation. But that's basically the what we call the face workup or the face evaluation. So I think at that point, I think the next step is sort of like once that diagnosis has been made, and I should say that quite a while ago, I think it's been almost 10 years or more, a group of us got together and we created diagnostic criteria. This was important to do because if you just take a baby with a hemangioma in the face and you do an MRI and an MRA on them, we were finding that there were certain blood vessel abnormalities that are so common in the population that we shouldn't really be calling them face because they could happen to someone. It could just be completely coincidental. So our goal was to sort of narrow down and be more precise with diagnosis, which I think we're successful in doing. The ultimate goal for all of us, of course, is to go ahead and try and find a cause, a lab test, something like that. But so far we have not been, unfortunately, successful in doing that. So why don't I turn it over to Dr. Beth Drolet, a longtime friend and colleague from Wisconsin. Take it away, Beth.
Perfect. Thanks, Ilona. I always like to think about the first face patient I saw, which was, I think in 95, Ilona, maybe 96. And I had a patient with a large facial hemangioma, and she also had a sternal cleft. And so my mentor, Nancy Esterly, said, no, you have to call Ilona. She's writing up a paper and, talking about, so it seems like so long ago, but yet not that long ago. And was able to talk to Ilona about a component of face syndrome. So as Ilona has talked about, once we make the diagnosis of face, that does help us to kind of look out for treat and maybe prevent some future health problems. So first and foremost, always in that first year of life is treating the hemangioma and making sure that as the child gets older with face, that the hemangioma is not growing, is not causing problems with vital structures like the eye, the ear, the nose, the airway, the lip, and also very importantly, not causing ulceration or potential for scarring. By far the best treatment for a proliferating hemangioma in a baby with face is oral propranolol. And we can talk a little bit more about that if folks have specific questions. Ilona and myself and our hemangioma investigator group have published 2 articles collectively on our experience in using this drug in patients with face syndrome and patients with a lot of the arterial changes in face. So there are some specific things that we do just to be a little bit more careful that we're not going to have alterations in heart rate or blood pressure because of the abnormal arteries, but we feel very strongly. And those of us that treated patients with PHACE before or propranolol know how incredibly aggressive these hemangiomas can be. And that this treatment with propranolol has really changed that in a very significant way. So as the kids get older, we do, depending on some of the features that Dr. Frieden had talked about, that will help direct which type of specialist your child might need to see. So if there are changes in the heart or in the aorta, pediatric cardiology will be very important. If there are changes either in the development of the brain or the cerebellum, or the arteries that feed the brain, a pediatric neurologist is very useful. If possible, we like to even get a little more specialized and have our pediatric neurologist who might look at blood flow issues in babies and children help us out. The dermatologist is another key role for management of the hemangioma, and also maybe some of the long-term effects, like, you know, talking about lasers or looking at hemangioma scarring or management of that. And then as well as ophthalmology. And again, this depends a little bit on that initial screening exam. And for most kids, if their eye is like totally normal, then we don't have to repeat. But if there are changes in the shape of the eye or in the optic nerve, that can be a really important part of the career. And then there's the care. And then there are, you know, very specific, you know, sort of some of the rarer findings that we can see with some of the screening that may look at, you know, pediatric endocrinologists, if there's growth problems, some of the physical therapy, if there's speech or swallowing problems, things like that. Probably one of the most controversial things is this next bullet, which is when to repeat imaging. So in the criteria that Dr. Frieden had talked about, there's sort of what I think about static changes. So some of the changes in the development of the brain and the cerebellum don't seem to change much, but we do sometimes see some of the artery abnormalities change. They don't always, and in fact, probably it's more rare that they don't change, but we still know that there can be some progression. And so usually we do a screening imaging. If there are changes in the arteries, we try to subclassify those into kind of 3 categories. We call them kind of low risk, medium risk, and high risk. And depending on the types of artery changes that your child might have, that really can dictate how frequently we will repeat the imaging. I will tell you, this is probably the hardest thing to figure out, and I think really hard for parents because they might hear a lot of different answers and very individualized. One thing that is very clear is that if your child has any changes in development, new onset severe headaches, migraines, or any other neurologic signs or symptoms, we do usually recommend repeating the imaging with some kind of acute changes as well. And then, of course, always kind of reaching out when you're ready to the family advocacy groups, which has just been, you know, another, just like propranolol, the PHACE syndrome has been such a game changer for families with rare disease, and being able to connect with folks that have gone through similar situations and being able to get really good information, because it is a rare disease and not every specialist is going to know about or hear about it. So with that, I'm going to turn it over to Mitchell, who's going to just talk a little bit about the long-term follow-up, which is what his research has been on.
Perfect. And this slide here is kind of just highlighting the 2016 study that really established the guidelines for diagnosis. And we've gone through a couple new studies in the past couple of years that I think is helpful to think about long-term trajectory or long-term course for people with PHACE. I'll go over this slide in a minute, and then the next slide I have some articles that I want you all to be aware of, that they exist. You do not need to read them in depth, but I think they can be really good resources to bring to your providers, like pediatricians, primary care providers, or other specialists who may not be as familiar with PHACE syndrome. So in general, we have looked at people who have face syndrome as they've gotten a little bit older and into adulthood. What tends to happen is that in infancy, they get a lot of focused medical care from dermatologists, neurologists, et cetera. But then over time, it's easier to kind of fall out of routine care. We recently went through a big cohort of kind of people older than the age of 10 and specifically looked at some things that have been reported in the literature already. So these are the highlights from that. First thing that what can happen with face syndrome is that we have found that individuals who have face tend to have more headaches that can be a little bit more severe and occur earlier on in childhood compared to people who do not have face. This can need neurology care, so someone who's a specialist in headaches, to help with prevention and help with limiting the impact it has on school and daily life. The hemangioma of infancy, we chatted about a little bit already. There can be residual changes left over from the initial growth in infancy. So we'll treat with propranolol. We usually get people off propranolol by the age of, 3 years or so. And then with time, there can still be some redness or some kind of redundancy in the tissue. And so having a dermatologist to go to can be really helpful for laser procedures or other types of modifying procedures. And then Dr. Drolet spoke already about the need for imaging. And so some providers think kind of around age 10 is when we should rethink this. Again, it's based on the risk stratification that happens kind of in infancy and whether or not there are new symptoms that happen, but it should be on our radar at least to consider it. And then primary care is really important long term. So there are certain things that can happen in face as people age. Growth related to hormones is one of them. And usually we can find that in kind of earlier childhood, but sometimes it goes missed. And so just keeping an eye on whether or not your kids are tracking along the growth curve is important. And then if there are any missed developmental milestones, or if there's an issue with school performance or work performance, many individuals with face end up getting individualized education plans as needed, very individual, but something to think about as kids go through elementary school and high school years. And then mental health, if there is any stigma related to hemangioma or other, and then being good about kind of vision, hearing, and then routine dental care as well. So this is on the Face Syndrome Community website. So you can just Google Face Syndrome Community, and there is a research tab at the top that then pops up a list of recently published articles. So this article on the left is a review article that's talked about what we've learned about face syndrome over the past 25 years or so since its kind of establishment. Good for primary care doctors if they need kind of a review on what the condition looks like and what the manifestations could be. And then this is the study of the 100-ish participants that we did looking at people as they've gotten older. If there are questions from you or other people in the specialty care group that need to learn more about what this syndrome can look like going forward. So I think with that, we can kind of turn it over to individual questions and fill in as needed. Stop the share for now.
Thank you. Good information. I did put a link to the website for the current research where we have all those articles. So be sure to take a look at that. I know there's a lot of information on there.
Okay, I might want to say, if I could say just two things about that FACE 25 years later paper. It's open access, so anyone can read it. There's no paywall. So that's very important for you. And also, it has a supplemental table, which basically says, if your child is X years of age, or if you're an adult with face, it's kind of a checklist of what you should be thinking about. So I really recommend that in particular. The checklist, there was an error in it, and so hopefully you get the most updated one, but even the one that had it had a minor error that we corrected. But it's I think it's great for primary care physicians so that they know what to be thinking about when they see your child or yourself if you have FACE. And then one other thing I want to highlight is the hearing, because one of the lessons that we've learned is that, virtually every baby, at least in the United States and I think North America, gets a hearing screen when they're born. But even if they pass that hearing screen, for us, I think we feel like that should probably be repeated at some point for FACE patients, and particularly if they have involvement of the hemangioma in and around the ear, because we've seen a number of patients where they pass the hearing screen and then they have a hearing issue that's detected later. And of course, the sooner you can detect hearing issues, the better in terms of interventions. So I just wanted to mention those two things.